Hello and welcome back to InterpreterPrep.com. This is our fourth and last presentation on the digestive system. Up until now, in our first presentation, we covered the mouth. In the second presentation, we covered the pharynx, esophagus, and stomach. In the third presentation, we covered the liver and gallbladder. Today, we'll be going over the pancreas, the small intestine, and the large intestine. And I want to remind everyone that although these presentations may serve to recognize signs and symptoms of diseases, they're not meant for that. The only person who can tell if you or anyone else may need a treatment is your doctor. So if in doubt, go see your doctor. I also want to say that the list of diseases we cover is limited. We only have 40 hours. The purpose of these presentations is to provide you with a basic, and I say basic, understanding of the health disease process to help you pass your certification exams and be a better interpreter. Having said this, let's get this presentation underway. Let me start by saying that the duodenum is where the small intestine starts. It's a loop of intestine that is wrapped around the head of the pancreas. In the image, thanks to the see-through effect, we observe the pancreatic duct coming down to join the common bile duct. Both ducts drain into the ampulla in the duodenum, also visible here because a part of the front wall of the duodenum was removed. Understanding how the gallbladder, pancreas, and duodenum relate to each other is important to understand some diseases. We can now understand that if a gallstone gets stuck in the ampulla, there will be a backup of secretions and increasing pressures in the ducts that can affect the gallbladder and or the pancreas. Also, if we get a cancer growing in the head of the pancreas, it can invade the common bile duct, squeezing it and causing bile to get backed up, and bilirubin starts leaking into the skin, so jaundice appears. That's easy to understand, right? It's easy once you know the anatomy of the biliary duct system. The pancreas is a gland located deep in the back of the abdomen. It's a hard worker. It does a double shift. It works as an exocrine gland, and it also works as an endocrine gland. Remember, all the secretions that go into the blood are endocrine secretions. Endo means inside. All the secretions that go elsewhere are exocrine secretions. Exo means outside. Here, we're only going to cover the exocrine function of the pancreas. Its endocrine function will be covered in the presentation on the endocrine system. Now, having said this, let me ask you a question. The principal organ of digestion is the stomach, right? No. Actually, it's the pancreas. The pancreas secretes digestive juices which contain enzymes. Enzymes like trypsin, which breaks down proteins, lipase, which breaks down fat. Fat is also known as lipids. Then we have amylase, which breaks down carbs. It also secretes sodium bicarbonate, which is not an enzyme. It's a buffer, which means it neutralizes the acid in the chyme coming from the stomach because the enzymes need a more, let's say, basic environment to work in. Well, we've talked about the duodenum and pancreas so far. Now, Let's see some signs of diseases when these organs get sick. When there's a problem in the duodenum or pancreas, a patient can come in complaining of abdominal pain, jaundice, or bleeding in the digestive tract, also known as melena. Now, let's mention a few diseases. We have duodenal ulcer. Most of the ulcers of the duodenum appear in the superior part as seen here. Ulcers are almost always associated with H. pylori infection. H. pylori is a bacteria. Peptic ulcers can appear in both the stomach and the duodenum, but the duodenal ulcers are much more frequent. Then we have pancreatic cancer. Luciano Pavarotti, Patrick Swayze, and Steve Jobs. Three famous people I can think of off the top of my head who we lost to this cancer. It has a bad prognosis and is generally inoperable, having spread to other organs when diagnosed. Then we have acute pancreatitis, which is the inflammation of the pancreas. It can be caused by gallstones, biliary sludge, or alcoholism. When bile gets thick, it's known as biliary sludge. A few diagnostic procedures used are barium meal. For this study, the patient swallows a solution that contains barium and then x-rays are taken. This way, if there's an ulcer, it gets coated with the barium solution, making it visible on the x-ray. So, what's the difference between a barium swallow and a barium meal? It's basically the same study, only that the barium swallow is focused on getting images of the esophagus, while the barium meal tells the radiologist that they want x-rays of the stomach and duodenum. Another study is an upper endoscopy. Upper endoscopy permits direct visualization of the duodenum. Then we have abdominal CT scan. The abdominal CT scan is useful to detect pancreatic tumors. Another study is fluoroscopy. It is a real-time X-ray seen on a monitor screen. A patient swallows a barium-impregnated solution, and the radiologist can observe the resulting moving images in real time as opposed to the still images obtained by a standard X-ray. Now let's mention some treatments. Antibiotics are used to treat alcoholic pancreatitis and H. pylori infections. Stomach protectors are prescribed for ulcers like omeprazole and ranitidine. Surgery. A type of surgery known as vagotomy is done to treat duodenal ulcers. The nerves that stimulate acid secretion in the stomach are cut. Then we have endoscopic retrograde cholangiopancreatography, also known as ERCP. It's an endoscopic procedure to visualize and clear out the ampulla in acute pancreatitis. It's so difficult to say that it's commonly referred to once again as ERCP. Now let's talk about the intestines. The intestines, also known as bowels, are divided into the small and large bowel. And if we remember that a quarter is worth 25 cents, then we can remember that the small intestine is about 20 feet long and the large intestine is about 5 feet long. The small intestine sits in the bottom half of the abdomen. It's divided into the following segments. The duodenum. We've already talked about the duodenum and its relationship with the pancreas and gallbladder. So now we'll comment on the next part of the small bowel called the jejunum. It's where most of the absorption takes place and is followed by the ileum, which is the last part of the small intestine where absorption continues and where vitamin B12 is absorbed. The absorption of the nutrients into the bloodstream is done through millions of tiny hair-like structures found in the lumen of the bowels, known as villi. The large intestine is divided into the cecum. Here in this image, in the lower left side, they removed a part of the intestinal wall to make the ileocecal valve and the cecum visible. The cecum is the first part of the large intestine and has the form of a pouch. The ileocecal valve marks the ending of the ileon and the start of the cecum. It's there to make sure that the content in the cecum won't reflux back into the ileum. The appendix is also connected to the cecum, as we see here in this image, where it's red and looks like a pig's tail. The appendix is a little piece of intestine which we really don't know too much about. It seems to have had something to do with our defenses when we were in the womb. Others say it was just put there to feed the surgeons who frequently remove it. Then we have the colon. The colon is seen here in red and is divided into 4 parts based on the colon's trajectory inside the abdomen. Now please follow me by starting at the bottom left of this image, where we have the ascending colon, which goes up until it turns to the left under the liver at what's known as the hepatic flexure. Then we have the transverse colon, which crosses the upper abdomen from side to side and then turns down at the spleen at what's known as the splenic flexure. Then we have the descending colon, and this part of the colon continues downward until it enters the pelvis, where it becomes known as the sigmoid colon. The sigmoid colon is called that way because it's shaped like an S. The sigmoid colon ends at the rectum. By the way, remember the spaghetti? It continued to be digested, and now it is no longer called bolus or chyme. At this point, it's basically loose fecal matter. In the cecum and first parts of the colon is where most of the water is absorbed. By the time what's left of our meal reaches the last parts of the colon, it's now semi-solid fecal matter. The fecal matter then reaches the last part of the large intestine, which is the rectum. As the rectum fills, you feel the urge to go. Thanks to the anal sphincter, which we see in this image of a cross-section of the rectum, you can hold it until you find a restroom. A sphincter is a circular band of muscle which keeps the rectum closed. When the rectum contracts, the sphincter relaxes and defecation occurs. The anus is the opening through which the feces are eliminated from the body, and it is partly mucous membrane and partly normal skin on its outer part. We have now reached the end of this journey. Now, let's talk about some signs of disease. When there's a problem in the intestines, a patient can come in complaining of pain, bloating due to gases, diarrhea, constipation, itch in anal disease, GI bleeding, also known as melena, and losing blood can cause you to feel fatigue, feel tired, which is a symptom of anemia. A patient can also come in complaining of fecal incontinence, and this is the patient that needs to use diapers. Now let's mention a few diseases. First we have celiac disease. In this disease, the intestinal villi is damaged and the patient needs a special diet due to malabsorption. This diet must exclude gluten, which is a protein found in grains like wheat, oat, barley, and rye. Then we have gastroenteritis. Gastroenteritis is a painful intestinal inflammation caused by food poisoning. It's also known as the stomach flu. We also have bowel obstruction. This means that the transit through the intestine is blocked. It can be due to internal scars, also known as adhesions, that appear after abdominal surgery, or it can also be caused by a hernia. Strangulation and death of the intestine may occur, making this a reason to go to the ER urgently. Then we have ileus. Ileus is a lack of intestinal paralysis. It can be caused by general anesthesia, and that's why the doctors won't let a patient go home until he swears he's passed some gas. We also have irritable bowel syndrome. Its acronym is IBS. You'll hear it mentioned under the acronym IBS, which once again means irritable bowel syndrome. It's a peristalsis disorder of the intestines, sort of like how the nutcracker esophagus was a peristalsis disorder of the esophagus. The intestines don't seem to coordinate well, and it's like several people rowing in the boat, and they're all paddling in different directions at different times. This condition seems to be stress-related, with symptoms like diarrhea and constipation. Then we have diarrhea. Diarrhea has many causes. It can be caused by germs like E. coli or Campylobacter. It can be due to malabsorption or lactose intolerance, which means that there's allergy to milk, dairy products. It can be also caused by irritable bowel syndrome or inflammatory bowel disease, which we'll mention in a little while. This next image will be great for our next three diseases. And our next disease is, matter of fact, inflammatory bowel disease, or IBD. Under this heading, we have diseases like ulcerative colitis and Crohn's disease, which are diseases that cause inflammation, ulcers, and scarring of the intestinal walls with bloody, watery diarrhea. Then we have polyposis, which are growths in the colon, some of which are benign, other times cancerous. Then we have diverticulosis. Diverticulosis is the presence of these little pouches in the intestinal wall found typically in the sigmoid colon. Diverticulosis becomes diverticulitis when one of these pouches gets inflamed. Patients with this disease need a special diet high in fiber to treat the constipation that comes with the disease. Then we have to mention colon and rectal cancer. In this image, we can see the 4 stages of colon cancer. The tumor grows, as we see in the image, until the last stage, which is stage 4, where it reaches the lymph nodes and spreads. That spreading of the cancer is also known as metastasis. Then we have hemorrhoids. Hemorrhoids is the presence of dilated veins in the rectum, as seen in this image of a cross-section of the rectum. Hemorrhoids can be internal, which can't be seen by looking at the anus, or be protruding, called external hemorrhoids. These are the ones that don't want to stay in, they want to go out, and these are the ones they operate. Then we have anal abscess and fistula. Let's go back and see that cross-section of the rectum to explain this. An abscess and a fistula are different stages of a same disease process. It all starts when one of the anal glands gets blocked and becomes infected, forming a localized collection of pus known as abscess. The abscess is sort of like a deep pimple. It can grow and wind up opening and draining to the skin around the anus. That open pathway from the gland out to the skin is called a fistula. We see in this image different varieties of fistulas. Last but not least, we have anal fissure. Anal fissure is an ulcer that appears on the anus and looks very much like a paper cut. It makes defecating very painful and is self-limited in most cases. A few of the diagnostic procedures used are, first we have rectal exam. This picture says it all. It's also known as a digital exam. As you can imagine, it consists in the introduction of a finger into the rectum. It's done to examine the rectum and the prostate gland. Then we have the CBC. CBC stands for complete blood count. It's useful to detect anemia due to chronic GI blood loss. Then we have colonoscopy, which is also known as lower GI endoscopy. It's done with a flexible tube which is inserted through the anus while the patient is sedated. It permits direct visualization of the colon as seen here. Samples of tissue, known as a biopsy, can also be taken during this procedure. Then we have the CT of the abdomen. CT stands for computerized tomography. Another way of saying it is CAT scan, and a CAT scan is not a diagnostic imaging study of a cat. CAT stands for computerized axial tomography. Another study is stool for occult blood. It's done by collecting samples of feces and testing them for the presence of blood. AXR means abdominal X-ray. Then we have abdominal ultrasound. It's done to view the pancreas, the common bile duct, and the gallbladder. Our last study on this list is the barium enema. A radiopaque contrast is administered through the rectum and images are obtained through fluoroscopy. Radiopaque means that it will look white on an X-ray. It's used to view the rectum and the sigmoid colon. Now, let's mention some treatments. We have medications such as immunosuppressants like prednisone and TNF blockers like etanercept. These medicines suppress the immune system, reducing inflammation. Then we have antidiarrheals like loperamide and laxatives, also known as stool softeners, which are used to reduce constipation. Then there's anti-inflammatory medication like mesalamine, which is used in ulcerative colitis. Another treatment is nasogastric suction. In this case, a tube is inserted through the nose and down to the small bowel to suck up gases and liquids from the intestine when there's an obstruction. There are certain surgeries used, like to treat cancer, or when we have a complete bowel obstruction, or they operate when there's a lesion that just doesn't stop bleeding. Appendectomy is used to treat appendicitis. Appendectomy is the removal of the appendix. Another is hemorrhoidectomy, and as we mentioned earlier, this procedure is used to remove or treat external hemorrhoids. Then we have colostomy. When a part of the colon is removed, what's left may be too short to reattach to the rectum, and so an opening called a stoma is created in the wall of the abdomen, and the colon is sutured in place there. A bag is placed to collect the feces which will be expelled. At other times, the colon can't be stitched back together immediately, so a temporary colostomy is done. In other words, colostomy can be temporary or permanent. In the image, we see two different colostomies, one done at the transverse colon and another done at the descending colon. And yet another one has been done at the small intestine, and in this case is known as an ileostomy. Then we have suppositories and sitz baths. They're used to treat hemorrhoids. Then we have chemotherapy and radiation therapy. These are both treatments for colon cancer, etc. And we have diet. Special diets rich in fiber are used for patients with diverticulosis, or diets devoid of gluten for patients with celiac disease. Last but not least, we have the enema. An enema is the introduction of liquids into the rectum and colon through the anus. It can be used to treat constipation. The specialists who treat these diseases are gastroenterologists and general surgeons. The specialty that deals with these diseases of the digestive system is known as gastroenterology. Just to be clear, gastroenterologists don't operate. So, for example, if a gastroenterologist diagnoses you with gallstones or appendicitis, he'll refer you to a general surgeon to get your gallbladder or appendix removed.